My topic is, it's known to each and everyone, and it's nothing new in it. We are reviewing it, that's all. This is a controversies to consensus. That is basically comparing the JNC 7 to JNC 8, that's all. This is the brief outline how we go through this lecture. And as we all know, hypertension is a very problematic thing all over the world and so also in India. There is a beautiful article published in 2012 in Journal of Hypertension, and the prevalence of prevalence of hypertension in India is around 30%, and it is more so in the urban population, and compared to the rural population, 33 versus 27. And over a period of 15 years, there was a steeper rise in the prevalence in urban population in India compared to the rural population. Despite all efforts to control the blood pressure and trying to increase the level of the awareness, still the level of hypertension, the prevalence of hypertension is increasing all over the world, including in India, because of the known facts. Because most of the times hypertensive patients, they are asymptomatic, the complaints will be less. That is the reason why the hypertension prevalence is increasing and treatment is not controlled to the optimal level. Before going to the actual controversies, let us see how historical aspect of the blood pressure measurement. The first blood pressure measurement was done by Stephen Hales in 1733. That is almost 300 years back. And at that time, he cannulated the carotid artery of the horse with a brass pipe and connected it to a glass tube using the trachea of a swan. That is how they measured the first blood pressure measurement in an animal, and that was water manometer. And after 100 years, second try was done by Poiseuille, and he has introduced the Mercury manometer, but this is also an invasive method and it is painful. And luckily, Laennec invented the stethoscope way back in 1817, but first blood pressure measurement, non-invasive way of blood pressure measurement by graph, that was recorded by Carl von Wernicke. I don't know how to spell it, but in 1854, there they recorded the pulse trace and write it on a drum. And sphygmomanometer, that is pulse manometer, using the cuff, rubber cuff by Dunlop company, that was invented by Rossi in 1890. From then onwards, it became a popular, sphygmomanometer became a popular instrument and most widely used instrument. And at that time, he used to measure the only systolic blood pressure by using the palpatory method. We all know the palpatory method. And credit goes to Korotkov, who is responsible for hearing the diastolic sounds and measuring the diastolic blood pressure using the stethoscope invented by Laennec. Since then, so many instruments were introduced, and till recently sigma manometer, Mercury sigma manometer was considered as the gold standard, but it has got its own pitfalls. The pitfalls are instrumental as well as physicians' pitfalls. Instrumental, even in country like England, the regular service in a hospital or a government hospital, that was 30% regular service. Because of that lack of regular service of the sigma manometer, blood pressure measurement was erroneously recorded and treated erroneously. So, what is an alternative to mercury manometer? Added to this, mercury is considered as a poison, environmental poison. So, in countries like Norway, they banned the mercury. So, they are keen to develop a new instrument by which we can measure the blood pressure. So, with this idea, so many instruments have come, that is Android manometers, and now we are getting a digital blood pressure measuring instruments. Each one has got its own pitfalls. Now, even in the studies, multicentric studies, we are using a digital manometers as a tool to measure the blood pressure. So, while taking the blood pressure, we have to follow certain principles. If we don't follow these principles, then we get errors in recording, and we should record measurements at 1 to 2 minutes intervals, and we should allow the patient to sit down at least for 5 minutes, then apply the cuff. All these things I think everyone knows. And what will happen if you don't follow these rules? If you don't allow the patient to rest for at least 5 minutes, blood pressure may go up to 12/6 millimeters of mercury. And if you don't support the back, it may go up to 6 millimeters. It may be raised by 6 millimeters. And level at which blood pressure cuff should be there, that has to be followed. And one should be careful to select a optimal size cuff, and also placing the cuff over the artery. And we should not allow the patient to talk during the measurement. If we do that, blood pressure may go up to 17 millimeters of systolic, may go by 17 millimeters rise. You should take 3 records and with 1 millimeter apart, and you can average it. If any one of the record is very high, you can average 2 records. It takes at least 10 minutes for us to measure the accurate blood pressure. So, because of, and there are certain pitfalls. With these pitfalls, can we avoid all these pitfalls? With this, some of the instruments came into picture, that is ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring, it records the blood pressure over a period of 24 hours at regular intervals, say about 15 minutes intervals. And it is closely correlated with the target organ damage, that is change blood pressure and ambulatory blood pressure recording, and kidney function, ambulatory blood pressure recording, and eye changes. All these things are closely correlated. That is the reason why ambulatory blood pressure monitoring is more accurate compared to the regular monitoring, that's regular blood pressure monitoring in the office. And additionally, ambulatory blood pressure can avoid white coat hypertension. And also, we can easily detect blood pressure raised during sleep, that is non-dippers. During sleep, blood pressure may go up. So, there is a study comparing the ambulatory blood pressure monitoring recording and systematically measured manometer measurement in the office as well as at home. Here, if we carefully measure the manometer measurements and simultaneously do the ambulatory blood pressure monitoring, there is a strong correlation between the two. So, people consider home blood pressure monitoring is almost equivalent to ambulatory blood pressure monitoring. Multiple recordings at the home, they are almost equivalent to ambulatory blood pressure monitoring. Main indications for ambulatory blood pressure monitoring are borderline hypertension, white coat hypertension, isolated systolic hypertension, and nocturnal rise in the blood pressure, and also it is very useful in resistant type of hypertensive patients and hypertension in pregnancy. And sometimes patient may have normal blood pressure, and if you apply the ABPM, you may see that patient may develop syncope just because there is a fall in the blood pressure during the daytime. So, hypertensive symptoms can be ruled out or it can be confirmed by ambulatory blood pressure monitoring. The normal values during the awake period is optimal is 130 by 80 and asleep it is 115 by and 120 during awake period, and asleep 125 by 60 is the abnormal recording. Still, ambulatory blood pressure has got its limitations, because ambulatory blood pressure means patient should be ambulatory 24 hours. That's not possible. So, there is a period by which patient is asleep or not ambulatory but sedentary. That is the reason why we may not get totally accurate measurement with the ambulatory blood pressure monitoring also. And it also technically it demands, there is a lot of demands discomfort to the patient, and is also more expensive than conventional measurements. So, coming to the guidelines proper, there are certain similarities between the different types of guidelines, and European guidelines and JNC 8 guidelines and American Heart Association guidelines and American hypertension guidelines, international hypertension guidelines. But as far as the JNC is concerned, thresholds for starting the pharmacotherapy is 140 by 90 if the person is below 60 years of age. But if the person is above 60 years, compared to the previous JNC guidelines, that is JNC 7, the threshold level increased to 150 by 90. So, these are the studies which support the treatment of drug therapy for hypertension if the blood pressure level is above 150 by 90 in persons above 60 years of age. And once we start, we should we should aim at to reach the level of less than 150 by 90 if the person is above 60 years of age. There are studies, two studies, which are against reducing the threshold level or reaching the level below which. These are the JETO studies and Valsartan elderly study. They clearly demonstrated that reducing the threshold level below 150 by 90 in any individual above 60 years of age, there is no additional advantage. There is no additional reduction in the mortality and morbidity. That is the reason why JNC 8, they fixed the threshold level and target to reach the goal is at 150 by 90 in persons above 60 years of age. But even the person is above 60 years of age, in specific special groups like blacks and high risk groups, high with multiple risk factors, again you can aim at goal of 140/90 and start treatment even when the blood pressure is just above the 140/90 millimeters of mercury. So coming to the persons below the 60 years of age, this is a standard, there is no controversy regarding this one. Anything above 140 and systolic and diastolic blood pressure above 90, we can start treatment with the drugs. But what about the persons below 30 and above 80? Below 30 and above 80, we follow the same guidelines as that of 30 to 60 years of age, because there is no clear-cut evidence to support this. There are no randomized controlled trials to say that this level should be reached. That is the reason why even in JNC 7 and 8, they fixed the level at 140 systolic and 90 diastolic, and goals are at 140 systolic and 90 diastolic. And even in the JNC 8 guidelines, the treatment is based on the ethnic group. That is, if the person is black or non-black, depending upon the ethnic group, they choose the drug. So if the person is non-black, thiazides like thiazides or thiazide-like diuretics and calcium channel blockers, ACE inhibitors and ARBs are the treatments of choice. If the person is a black, one should not use ARBs and ACE inhibitors as the first line drug of therapy. Then better start with thiazides and calcium channel blockers. Drug therapy in persons with CKD, if the creatinine level or potassium level permits, then better start with ACE inhibitors and ARBs to improve the kidney function and reduce the intraglomerular hypertension. What about the role of the beta blockers? Beta blockers was in the front line when JNC 7 guidelines were introduced, but when it comes to the JNC 8, they withdrew the beta blocker from the list. There are two studies in which beta blockers proved ineffective, rather not sufficiently effective. So one is a live study where they compared the ACE inhibitor with the beta blocker atenolol. Atenolol is not, even though it is effective, but it is not as effective as ARBs, that is losartan potassium. So that is the reason why they withdrew this one from the. And another study is ESCOP study. There they clearly demonstrated that persons with atenolol, they have more number of strokes. That doesn't mean that it produces strokes. The number of strokes reduction is less compared to the other drugs like ARBs and ACE inhibitors. That is the reason why beta blockers were not the first line of drug now. And coming to the newer beta blockers and third generation beta blockers like nebivolol can be used as this is a class E recommendation, that is an expert opinion recommendation. If we feel, experts feel that beta blockers is the treatment of choice for that particular gentleman, you can start this first line, third generation beta blockers as the first line treatment. There are certain recent trials which are conducted wherein why should we fix it as a 140, why not go a little bit lower, because in other studies, the lower the blood pressure level, the greater the outcome. That's what we observed in the earlier studies. There are two important studies. That is, one is the SPRINT study and the HOPE-3 blood pressure study. Coming to the SPRINT study, they have taken a intensive group and standard treatment group. In the intensive group, they measure, their goal was to reduce the systolic blood pressure less than 120 and compared to the standard group less than 140 in non-diabetics. The primary outcome was expected was myocardial infarction, ACS, stroke, and acute decompensated heart failure and cardiovascular death. There is a 20% reduction in the primary outcome in those persons treated with intensive care of treatment. That is, those who achieved 120 by 90 blood pressure, that is systolic one less than 120 and then diastolic less than 90. But there are considerable number of hypertensive patients, and increase in the creatinine was observed in those patients who received intensive treatment. But this decline in the GFR is attributed to harmless hemodynamic changes in the kidney, or there must be a serious injury to the kidney that they could not clear it. They conclude that blood pressure aiming to reduce to 120 by 90 is equally good, and there is a 25% reduction in the mortality and morbidity, but one must be very cautious that patient may land in kidney insufficiency. That should be very careful. You have to be monitored carefully. So if we practice SPRINT study in India, in practice, common practice, you have to follow strict measurements of the blood pressure. That is, one should take at least 5 minutes to measure the blood pressure and take multiple records and average it, then only put the start the treatment if the patient has got a threshold level of blood pressure. Otherwise, you may land in patients, more and more number of patients going into hypotension, because in some studies they showed that if we follow strict these blood pressure measurement guidelines, substantial number of patients showed lower level of blood pressure if we at the end of the measurements, at the end of 5 measurements or say 6 measurements, or then you don't start the treatment and your patient may not land in hypotension and then renal insufficiency. That is the reason why method of blood pressure measurement is more important. They stress more on the blood pressure measurement. And another important point they noticed is the chlorthalidone is superior to other diuretics, and also they say amlodipine is the treatment of choice and beta blockers are less effective. And the second study is HOPE-3 blood pressure trial. This is in intermediate cardiovascular risk treatment group. The primary outcome was, the expected was cardiovascular cause, death from cardiovascular causes, non-fatal myocardial infarction or non-fatal stroke, and resuscitated cardiac arrest, heart failure and revascularization. In this, there is no significant reduction in the outcomes at the end of the study. So there is no significant difference in the individual components of the outcome, either the total mortality or individual outcome subsets. So in the subgroup of analysis, active treatment group had minimal reduction in the outcomes than the placebo. That is the reason why they said, they conclude that reducing the blood pressure below 120 is not useful, it may be harmful. That is the reason why they stressed more on the blood pressure measurement, method of blood pressure measurement. That is more important. One should not land in hypotension during the treatment. So they conclude that lower is better hypothesis is not correct. So based on this study, the JNC guidelines, they fixed the thresholds at 140 systole and 90 diastole. In special cases like kidney and diabetes, there is a study, Accord BP study, there also. In this study, in patients with diabetes and aiming at a target blood pressure of 120 by 90, there is no, compared to the 140 millimeters of mercury, there is no significant difference in the composite endpoints or fatal myocardial infarction or non-fatal major cardiovascular events. Coming to the, when do we give treatment? Whether you choose a morning dose or evening dose. They have conducted a multi-analysis study in Cochrane review, and in that there are no randomized control trials to solve this issue, but there is a evidence to say that evening dose is slightly superior to the morning dose, but there is no clinical significance. We need a more and more number of randomized control trials for this. So this is one of the study, MAPEX study, in which there is a slight reduction in those patients who received the blood pressure pill in the evening. And some other studies are going on, that is the time study and HIGEA trial study. We are expecting those results in 2019 and 2020. So, conclusion, hypertension is a continuous public health problem, and methodology of blood pressure measurement is more important, and ambulatory blood pressure measurement is useful tool, but it's not mandatory. Although recent trials have provided useful information regarding lowering the blood pressure further down to 120 by 70, but still our guidelines say that it should be around 140 by 90. Choice of blood pressure control should be individualized, and we need more data regarding the evening dose of antihypertensive drug. And we need more and more trials from India. That's what we expect. Thank you.